when we talk about recent advances in pediatrics, and I think that you will see that occurring more and more, and us paying more and more attention to it in many parts of the world. Now, when I was asked to talk about advances in pediatric critical care, I thought the best way to start is to look at ABC Medical News to see what they thought advances were. And you can see the top 10 advances of the decade that they spoke about. It has very little to do with critical care. And furthermore, it really got me thinking about what really is an advance. In the long run, I think that what we'd like to do is make a difference in the care of patients and the outcomes and the experience of patients. So many of what they are mentioning may be tools to achieve this advance, but it's certainly not advances. I think it's a very important topic at this time, and mainly we can look at if we decide that one of the advances in critical care is the need for critical care, or the number of areas of the world or populations that meet criteria for critical care or intensive care facilities. This has changed over the last few decades. For instance, the well-established or well-recognized criteria for providing publicly funded intensive care is a child mortality, under 5 mortality of less than 30 per 1,000. And one can see in this slide that in 1960, there were many areas of the world that did not qualify based on these criteria. Indeed, most of the developing world and many of the industrialized nations did not. Well, if we fast forward to a few years ago, we can now see that many of the developing world and most of the industrialized world fit these criteria, and hence more and more ICUs are being developed across the world. And as I said, we can think of that as one advance. But in thinking of it in a more sort of deeper sense, several questions were raised. Is that what is an advance? Is it better outcomes for patients, better integration of all aspects of care? Is that an advance? Ensuring sustainability of critical care? Or are we justifying critical care in more and more areas? In other words, advocacy, are those advances? And then for whom? As you heard, for the individual patient, is it population, clinicians, family, policymakers, or is it for all of those? And where in the world are we referring to? Because there are different resource limitations in various parts of the world. In some areas, we have an abundance of resources, and an advance in one area will bear little relevance to people in other areas of the world. So I thought that what aspect of care are we interested in? And if we go back to the Institute of Medicine, the dimensions of care that they espouse were effectiveness, safety, efficiency, patient-centered, timeliness, and equity. And I thought this might be a very good framework to look at advances that we have. And the reason for that is that there is a care system, and in the care system, as you can see, there are many factors that is required to provide better outcomes, safe, effective care. We need a supportive system with that is adequately sort of resourced. We need organization, as Andrew was talking about. We need high-performance teams. And we need a lot of enablers, okay, design of the systems, etc., that will lead to better outcomes and timely care. So with that in mind, I thought I'd like to sort of look at in various areas of the world in both resource-rich and resource-poor, because of the nature and the collaboration we have to look at some of the advances. When we think about effectiveness, there is no doubt that one of the gold standards should be the global trends in childhood deaths. And one can see the good news is that over the last decade, there has been a decrease in childhood deaths worldwide. Most of these deaths, as you know, occur in sub-Saharan Africa and Asia, but decrease in diarrheal diseases, malaria, mumps, measles, neonatal mortality, there has been decreases. So that's a good news, and one can say that based on that, the provision of care in general and the provision of critical care, we have made advances. This does not really tell us what the advances, but I would suggest to you that it is multifactorial in anywhere from prevention, immunization, etc., to provision of critical care. If we look at the developed world, there's very little literature, but in Australia, one can see the intensive care mortality has decreased from the 1980s of 15% to 5% in 2006. The more recent data from US 5 academic teaching hospitals that is not yet published, mortality rate is about 2.5% with a range of 2 to 3. Now, when we look at specific diseases too, and complex cardiovascular surgery for congenital heart disease, one can see the mortality has declined by 24% over a matter of a decade. So we can see that likely the care has improved in those patients. And the dramatic change to a large extent has been in neonatal mortality, where one can see the dramatic decrease in mortality due to a variety of factors again, but overall better care, better techniques in surgery, better post-operative care. In South Africa, this is some data from here we see with PICU survival of patients with HIV and PCP, and one can see that with different interventions from ventilation, steroids, etc., in a matter of 5 years, one can see a dramatic decrease in mortality from approximately 90% to about 22%. Again, so if we think in terms of that, there have been advances in various parts of the world. Now, safety is one of the issues that we have really taken to very, very seriously again. And as Andrew mentioned, we talk about well-functioning teams. Well-functioning teams within the ICU where they're staffed with different levels, different skills, different background and training, but also the well-functioning teams between the ICU and operating room transfers and teams that work close together. We have also had a burgeoning number of checklists, bundles, protocols, safe surgery, ventilator-associated pneumonia, line placement and maintenance, sepsis protocols, post-operative care, and you name it. Many of the units, as you heard yesterday when Jean-Louis Vincent talked, the number of protocols that we have. There's also a downside to protocols, etc. But the point is that it has increased communication in many areas, and in many areas we are seeing the benefit of this from better, less complications and better outcomes. Another advance has been in safety has been looking at one of the most common drugs that we give, fluids, and the realization that hypotonic fluids has a downside to it. Indeed, there has been morbidity associated with it and mortality, and in many cases now institutions have labeled the hypotonic solutions as a cytotoxic agent. In many cases, it's removed from certain clinical care areas, such that as a safety mechanism that you have to make a special effort to order it and to get it to be used. Some of you may have heard about this youngster, Rory Staunton, in New York, who was fairly normal, playing basketball, had a scrape, and ended up going to one of the institutions there, treated as just having a minor viral infection, given some fluid, sent home, and 24 hours later he returned to the institution and died. There was a lot of press associated around it, many reports in the newspaper, and indeed parents who read that was better educated to advocate for their child. And in one hospital in Florida, as you see, the mother insisted that her child had sepsis, which as it turned out to be. That by itself is one sort of sentinel event that has galvanized the issue of sepsis in New York State, and indeed the governor of New York has suggested that all, in fact, making a law of it, Roy Staunton law, that all hospitals screen for sepsis. Well, there have been a lot of work being done on sepsis, and you've heard a lot during this conference on various aspects of sepsis. But this study is from Texas, which showed that with good implementation of protocols, and as you can see the statistical control charts, they have been able to be aggressive in treatment. Time to fluid boluses and antibiotics have improved markedly. And with that, there has been a decrease in mortality from 4% to 2.5%, decrease in the use of vasoactive drugs and mechanical ventilations. This similarly in Boston, they use other criteria, for instance, antibiotics, inotrope support, vascular access, and recognition of sepsis as their hallmarks of treatment. And with their protocols, they have been able to increase adherence of it, but 57% reduction in hospital and PICU admission. In Utah, similarly for sepsis, they found that with appropriate sort of institution of guidelines, there was increase in protocol compliance from 60 to 80%. They gave the same fluid boluses very aggressively and were able to decrease mortality and decrease the length of stay. So the point is that this is in one area, one can say it's with one specific entity, but there are other collaboratives that have been showing very good results lately, and the building of collaboratives and community of practice, both in clinical care and research, as I mentioned yesterday, has been one of the advances, I think, in critical care. It's very interesting and ironic that many of our problems in critical care are safety, quality and safety issues due to lack of poor communication. But I think that one of the great advances has been communication and collaboration. And this is some data from Cincinnati, which shows that compliance with the bundles, the catheter-related bundles have increased, and at the same time, infection has decreased. This is hospital-wide, and we also have data now where several hospitals have done the same thing. There have been advances looking at issues in low-resource or low-income countries also, and this is pediatric quality of inpatient indicators, and this is now being used in several countries, also in Africa and Asia. And I think that this is one of the issues that has plagued us for years. The issue of quality of care in these areas have not really been addressed. And I think having a tool and having individuals who are now vested in addressing these issues is an increase. Indeed, global initiative to improve hospital care for children are occurring in many areas. You can see in Malawi, Hospital QI Project, Solomon Islands, Niger, South Africa, Papua New Guinea are doing mortality audits, and Commonwealth of Independent States are doing assessment of hospital care. So once there's a framework and we've started this, I think that we're reaching a tipping point now where it is no longer foreign to be talking about initiatives to improve care. Efficiency again plagues us. I think in the world of plenty, we have the luxury to do things in a different way, and in many cases we are less efficient. But I think we have a lot to learn from areas in which there are less resources, and this is from our colleague Gregor Polak in Malawi, in which there are few ICU beds, as we know. There are many children that are seen, and they cannot comply with the standard treatment that we speak about for sepsis. There are few anesthesiologists and very few doctors, as Andrew mentioned, the very same issue in South Africa. They are less resourced in Malawi. So he came up with a group with a very innovative program to prevent unnecessary admissions to the ICU. And they did that in several ways. They prevented elective operation and invasive procedures in malnourished children. So they had nurses as the gatekeepers, health surveillance in the villages, safe surgery campaign, they put a checklist in place, improve referral timing, prevent long fasting times so kids were getting the antibiotics and antimalarials were not being omitted. They were training people in the various relevant health areas to take care of children upstream, both mothers and children, so they did not come. And it made some difference. They've just getting the results of their program, but there's great hope that this will make a difference. Efficiency and innovation. There are many different types of ventilators that are now being modified for low resource setting. As Liz gave me some of this, desperate attempts to give oxygen, etc. But in resource-limited areas, there are many innovations that are now coming out that really increases efficiency. Patient-centered care, I will spend very little time on it. Andrew has done a very stellar job on speaking of what is needed in patient-centered care. But it is very interesting in the past year that there are many areas that are now discussing it. In Canada, the issue of whether the ICU is an office or a bedroom and how do we increase family-centered care in the PICU. Pakistan, you can see family-centered rounds in Pakistani PICU. And in US, factors associated with high-quality communication to families are all being discussed very vigorously. And in many cases, the issues in the past of does the family belong at the bedside is becoming moot. The issue of pain and suffering, Andrew mentioned that. This is from Liz again, speaking about healthcare workers are ill-equipped to manage pain in her area. But the interesting thing is that she said advocacy and commitment is needed. This is a shameful deficiency in healthcare provision, and we have the capacity to do something about it. But it's good news, at least we are starting the discussion in some areas. Treatment of children with cancer. In many areas, there is absolutely no treatment, or those that are treated, they suffer needlessly, again, in pain, especially at the end of life. There are now guidelines that are being discussed for cancer care in low-income settings, such that it does not strain the resources of the nations, but at the same time it provides humane care for children. So I think that this is also an area that we are seeing some advance. In fact, some of my colleagues who work in Bangladesh and some areas in Africa to enact this very program. Well, what about timeliness of care? I think timeliness is a problem, and for many of the diseases that we treat, the fact is that we need to give treatment in a very sort of quick manner. The fact is that there is very little time for deliberation. The fact is, in many parts of the world, the critically ill child does not have the families don't have the luxury of transport systems and well-integrated systems. And in many areas of the world, innovative solutions are now improving timeliness of care for children. For instance, community health workers' use of rapid diagnostic tests and drugs to manage malaria and pneumonia have decreased mortality, reduced drug use, etc. in several areas of the world. You can see in Zambia, in other areas, given oxygen at home or daycare clinics and those things have precluded the necessity for children to come to hospitals, which in many cases they cannot, they arrive in dire straits if they do. And home-based treatment can be applied in a variety of settings. You can see in Bangladesh, Egypt, Ghana, Vietnam, all improving outcomes and decreasing mortality. Innovative solutions, again, where there's a lack of medical or few medical care, training villagers in basic first aid, provision of antibiotics, again, to healthcare workers in Pakistan, modifications of some of the integrated management of childhood diseases protocols in the district hospitals, reorganization of emergency medical services, for instance, what Liz Molden has done and we have done in Bangladesh and China, where we've introduced triage in many hospitals such that it is not a first come, first served basis where critically ill children are waiting, has decreased mortality. And again, provision of oxygen in various settings since pneumonia is the most common disease. Now, equity is still an issue, and I think that when we look at it, this is the OECD data looking at the resources and dollars that have been given to countries, low-income countries, or countries which we said count down the priority countries. The priority countries are 70 countries in which 95% of the childhood deaths occur. And this graph looks at the resources that have been given in the last 10 years for maternal health and child health. But in all cases, what is worrisome is that the aid has been increasing for years, but it's only in the last 2 years one can see it is level off, and it is very worrisome for many in those areas because it has increased inequity, and it could spell disaster for many mothers and children. Indeed, this is a graph that shows child mortality, under 5 mortality on the vertical axis over income per GDP over many years, and one can see the progress. Those United States, Canada, Japan, few of the developed countries, one can see the dramatic decline in child mortality such that most are very low. But many of the countries up here, the African countries, have remained stagnant. In fact, some have made modest progress, and then there have been problems and regression again. And this is South Africa here, where there has been some progress, but not enough. So there's a lot more to be done there. Indeed, if we look at changes in mortality by wealth, we find that the problem is that there has been a lot of discrepancy, even in this area where children mortality has decreased. Under 5 mortality, in many countries, the ones in red, the discrepancy has increased such that the child in poverty has a markedly higher chance of dying than they were in the 1990s. So in the 1990s, there may be 14 times higher chance of dying. Now it's a lot higher than that. It's in the 20s of dying from poverty. So there's a lot more work to do in equity. And finally, in innovations, I think we've had some changes in kinder, gentler ventilation. Andrew spoke about the sedation, the approach to analgesia has been a boon for children. And in neurocritical care, we've had several development, the use of hypertonic saline, better monitoring, and the use of hypothermia. In fact, there's some interesting data that shows that patients who are going on ECMO now have a lower pH and a higher PCO2, implying that they are being ventilated and we are tolerating higher CO2s, lower pH, kinder, gentler ventilation, and they're going on later now on ECMO. When we talk about ECMO innovation, there are new centrifugal pumps that are also better, less complications. But again, as I said, when you talk about these as innovations, they occur in a different world than where most children die. There are better ways of looking at the brain for traumatic brain injury that has also been a boon. And this is a story of a young girl in Boston who is waiting for heart transplant from a dilated cardiomyopathy. She now has an artificial heart, but is at school and doing many of the activities she did before. Now, one can say it's an advance, but it's an advance for one person or for limited number will have access to this advance. In the larger world, liberation technology, it works very well for maternal and child death has decreased, where community health workers have been using text messages and reminding people with life-threatening complications that most of the life-threatening deliveries are now occurring in facilities rather than a thing. Pulse oximeter, we are making great inroads by using it as a diagnostic test or collecting data, put into a central repository linked to protocols such that people in villages, etc., can use that. And finally, we are starting more and more advanced with education, understanding adult education, and the OPENPediatrics is one method that I hope that many of you will hear more about it and go on site. We are in many countries right now, which is a very good advance. So in summary, when we talk about recent advances in critical care, I pose a question to you, is really what is an advance? And I think that for different people, it's going to be in the eyes of the beholder, where you are in the world, what an advance is going to be. For whom it's going to be is one of the questions you have to do. And as I say, what aspect of care are we really interested in? So I hope I've given you a sort of broad panoramic view of what I think are the various facets of advance. And I think that depending on where you sit in the world, you may or may not see it in different light. Thank you very much.
Please help us improve the content by providing us with some feedback.